I will be talking to you today about sepsis. It's a huge initiative that has gone now international to prevent infection and death from infection. And that's what sepsis is. Sepsis is infection that will kill you. And if we can identify it early, if we can identify it in the field, and we can identify it to the providers of care, we can give better interventions and have better outcomes in our community. So we'll go into different parts of it. Sepsis is the leading cause of death in non-cardiac units. So that means outside of ICU, this is what people are dying from on the floors in the hospitals. It is now the 10th leading. This slide shows it as the 11th leading. Now it is the 10th leading cause of death overall in the United States. And in 2000, it was reported that the estimated amount of people affected by severe sepsis was 751,000 per year, resulting in 215,000 deaths and $16.9 billion in healthcare money going towards treatment of these patients. So how deadly is sepsis? If you compare it with acute MI, lung cancer, colon cancer, breast cancer, it is more lethal than all of those. It is a medical emergency, just like a heart attack or a stroke. And it's because there's an interruption of oxygen and nutrients to the tissues involving all the vital organs, including the brain, the liver, the kidneys, and your lungs. Now, as septic inflammation progresses and new onset organ dysfunction is noted, mortality will increase. So if you get an infection and it affects one part of your body, one organ, you're going to have a 20% mortality rate. If you get up to 4 organs being involved, so your kidneys, your liver, if you're predisposed to having problems with those organs, you're at a 76% mortality. So that's a very bad outcome. And when the National Sepsis Initiative started, our mortality rates for sepsis across the country were at 80% before we were identifying and treating these patients early. We've got it down below 30% as a nation, and we're working each day just trying to find different ways to identify how to reduce the risk of those patients. So some of our risk factors, unfortunately, age. Age is a big one. 60% of the deaths of sepsis are over the age of 65. So you really, unfortunately, this is something that you're going to see in your community, you're going to see with your neighbors, and it's something that you can really help us reduce the risk of. Medical condition, any invasive devices, and this is why we try to get the Foley catheters out. We want to get the IVs. We don't want to keep PICC lines in forever because it's going to increase your risk from infection from these devices. Compromised immune systems, these are your COPDers that are on steroids, your chemo patients, anybody that's taking things that are going to reduce their immune response are going to be at higher risk from infection from those things. So genetics, other causes can be part of that. Again, on the age, under 10 years old, any child with a fever under a year of age is automatic sepsis. They are treated as sepsis. We stabilize them in our ER and we get them to a pediatric center. Because under a year old with that high fever, that's a septic baby and that's a problem. Over the age of 70 is, again, another risk factor for age. And medical conditions, alcoholism, any drug use, cancers, pneumonia, liver cirrhosis, diabetes are all going to put you at a higher risk from sepsis. So here's the hospitalization rates for sepsis by age. If you look all the way to the right, that's 85 and older. That's the age range that's really going to have a huge effect from these infections. Again, that 75 to 84 is a little bit higher too. But over 65 and older is going to be the majority of our septic patients that we're going to see. And they're seeing an annualized increase of sepsis, even if you look at the population growth, that we're seeing an increase of 8% each year of patients developing these sepsis. So this could be related to antibiotic use, inappropriate antibiotic use, and then just getting those lines and everything, keeping them in too long, surgical site infections, things like that are really increasing that problem. So again, those risk factors, those invasive devices. So if you see a dialysis patient that has that dialysis catheter, they're going to be at a higher risk for infection from those. Endotracheal tubes, if you have to get intubated for an airway, you're going to be at a higher risk for infection from those tubes. And just being on a ventilator, you're at high risk for pneumonias from being on, just from your oral mucosa, from being on those ventilators. Compromised immune systems that are weakened, we talked about that earlier. Obviously, HIV and AIDS is going to be a high risk because of their T cell production. Any kind of steroid therapy, IV drug use, all increasing your risk for sepsis. And then major surgeries, if anybody's had a surgery or a complication from a surgery, you can see that, those type of things. So these are things that should come up when if you are getting a patient that they've said they've recently been in the hospital, they've recently been treated for an infection. These are flags for sepsis for us because probably whatever they were treating with on the outpatient setting wasn't working for their infection. They were having problems with it. So what is sepsis? It's a big word. We're not really quite sure what it means. But sepsis is defined as a systemic response to infection. So it's not the infection that's causing it, very similar to anaphylaxis from allergic reaction. It's not the bee sting, it's your body's response to the bee. And in sepsis, it's your body's response to that infection that's going to cause you problems. You're in a sympathetic response. Your sympathetic nervous system is going crazy because it does not like this infection that's been introduced to its system. It goes into 4 different stages. You have your SIRS, which is that systemic inflammatory response syndrome. You have to pair that with infection to have sepsis. Without infection, you just have a systemic response. It could be just distress. If you increase your heart rate because you're mad and your blood pressure goes up or changes because you're frustrated, that's not going to be sepsis. You have to have a source of infection. Sepsis ranges from less to more severe. As it worsens, blood flow to vital organs becomes impaired. It can lead to blood clots to form in organs in the arms, legs, fingers, and toes, leading to varying degrees of organ failure and tissue death. Now, sepsis is very similar to trauma. It's just your mechanism of injury, instead of being from a car or a loss of limb, it's from your body's response to this really bad source of infection. So SIRS, the systemic response, it's nonspecific. It can be caused by ischemia, inflammation, trauma, infection, and a combination. Again, you have to have infection with it for it to be sepsis. It's the host response to the critical illness. So this is a very good picture of sepsis. It's a little bit, it's a little deep in the immune system, but when the immune system is stimulated, you have macrophages and T cells that travel to the site of the infection. When the process becomes exaggerated, inflammation extends beyond the infection site and affects the whole body. This widespread inflammation prompts the formation of microscopic blood clots in the blood vessels throughout the body. So at the same time, you have an inflammatory response, and it affects the body's ability to break down the clots. And then your body starts to shift all these platelets to those areas, and it quickly runs out of clotting factor. This situation is known as DIC. You see it in trauma. You also see it in sepsis. It's disseminated intravascular coagulation. And it's a very strange phenomenon because what happens is the inflammation goes in, clots build up, our body tries to break up those clots, and in doing so, loses all of its clotting factor, and we actually bleed out. We bleed to death. We lose volume, we lose blood, we cannot clot our blood, and we cannot sustain life. So it's a very interesting response because we never looked at infection that way. We looked at trauma that way. We know if I take your arm off and your body's going to try to clot that area, it's going to run out, and then you're going to bleed out. But we never thought of that with infection. And the more that we learn with sepsis, the more that we're seeing that. So these are the actual criteria we're looking at in the hospital to call our sepsis alerts. A temperature less than 96.8 or greater than 100.4. So if you think, well, why would a temperature low be concerning for infection? Well, the body, after a while of trying to give you that fever to break that infection up, it cannot sustain that any longer. So what you'll start to find, they call it cold sepsis. So their bodies tried to respond, can't respond anymore. Now we see the body temperature dropping. It's a bad sign. It's a latent sign. So you might find that patient that has a source of infection, that's weak, that's confused, and they're cold. And you're not thinking infection, but that's actually what's going on. Your heart rate greater than 90 beats per minute. This can be tricky with our beta blocker patients, our ACE inhibitors. We take medicines that prevent our heart rate to respond, so we're not going to always see that in a patient on low pressure, lisinopril, anything like that. So just be aware of that. Tachypnea is a huge sign. These guys are going to be breathing fast. They're breathing fast because they're trying to get oxygen to tissue that is not getting oxygenated. So that's going to be our body's response to try to make up for it. It's also trying to deal with the acidosis that the body's creating. So it's trying to blow off that CO2 and prevent that. And then again, our white blood count, greater than 12,000, or in a system that's just completely exhausted, they're going to start to drop their white counts because their body can't even keep up with the cell production for that. And then again, O2 sats that just keep going down regardless if they're on a ventilator or not. So if you have 2 of those SIRS criteria, and documented or suspected infection, that's what we want to start thinking of as sepsis. And then sepsis, time is tissue. It's just the same as with stroke alerts. It's the same as with cardiac events. We want to get in there. We want to give rapid fluid resuscitation. We want to give antibiotics. We want to identify this right away. We want to treat it right away. Within 6 hours, we want to have all the treatments done, and now we are going to just making sure that we're having good response to what we're doing with these patients. Severe sepsis is the next step where you've gone from that SIRS into sepsis into severe sepsis, and now you're getting some of those clinical signs and symptoms. Mottled skin because they have that decreased blood flow. They're clotting in weird places. They don't have the clotting factor. Their blood pressure is going down. Their lactic acids are going up. Tissue is breaking down, and the side effect for tissue breakdown is lactic acid. So we start to see it go higher and higher and higher. Anything over 4 is considered elevated for sepsis, and actually at South Bay we lowered it to 2 because in the elderly population we really need to be aware of that. So if we see it over 2, we start to treat it as sepsis even though it's not at that 4 standard. Urine output, that's your kidneys are shutting down. When we get into a shocky situation, our kidneys don't want to produce urine because they don't know how much fluid we're going to need. So they just stop. They hold on to everything that we got. So urine output goes down, and we get that change in mental status. Again, that platelet count, because we had those little clots. Body's throwing all the platelets at it, and now we've run out of platelets and clotting factor. And then elevated procalcitonin levels. So once you get through that severe sepsis, if we don't identify and really start treating it, we get to septic shock. And septic shock is you have all of those things, but you have very, very, very low blood pressure. You just don't have the circulating volume. The pump's not there working. Your body's shutting down. There's not much that it's able to do for itself anymore. So what we have to do in the hospital is we want to give you fluid, but we got to give you some pressors to get that blood pressure back up and clamp down those vessels that we can sustain some life with you. So some of our goals of the initiative for sepsis is preventing progression of sepsis, reducing mortality, and early recognition and treatment. We want to determine what the source of infection is, but we want to treat it before we even know. We want to give you antibiotics that are broad spectrum. We don't care what your source is. We'll find out in the next 4 to 6 hours, but we want to treat you. So the use of what they call early goal-directed therapy, that's the new movement with sepsis, and it's saying that we're going to do stuff quick, we're going to monitor our pressures, we're going to make sure everything's working, and we're going to keep on it. We're going to be very, 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 aggressive in our therapy with sepsis. So how can you guys help? Well, EMS can help greatly. Greater than 1/3 of the emergency departments with infections receive their patients through the EMS system. And I would venture to say at South Bay even probably 50 to 60% of our patients are coming in through ambulance. These guys are sick. They're coming from nursing homes. They're coming from home. They had a failure of a treatment outpatient-wise. They're coming in through you. You're usually going to be our first eyes on those patients, and that's huge for us to identify, and that's our main purpose. There is one Hillsborough County rescue unit, I think 11, that is now doing lactic acid in the field to try to identify, and they're just doing a study to see if that's going to help. But more and more studies have shown that you guys can definitely make the difference for that early identification. So we can reduce morbidity and mortality up to 20% just from you guys being able to identify that and letting us know that that's what you're seeing. And it's decreased time to the hospital, decreased time that they're going to be in the hospital if we can get that early enough. So I've made these little handy dandy cards for you I'm going to be giving out. And we're calling it the rule of 100. And a lot of facilities have sort of gone to this to make it easier. Because if you go back to that SIRS criteria, we got all these parameters and this and that. Let's keep it simple. So the rule of 100 for seeing sepsis is saying, is their temperature above 100? Now, you don't have thermometers. I know that's a challenge. But you can feel them. Are they hot? Are they confused and really cold and they've been treated for UTI? I mean, look, just see. Most of our septic patients come in hot, very hot. And we'll actually get a temperature and it reads normal. And then when we do a rectal temperature, they're 104. And it's because they're not perfusing. They got those little clots. They're not perfusing to their extremity. Their body is protecting everything that it has in the core. And we want to look at their heart rate. Is it above 100? Now, again, your patient that had multiple MIs, that's on more low pressure than they could shake a stick at, they're not going to see that heart rate respond to it. So you're going to have to sort of look at that, and that's going to be a challenge that you may have. But if you see the heart rate over 100, and a lot of times we are seeing that, and then that blood pressure below 100, that's our rule of 100. We want to think sepsis. And then do we have a suspected infection? Is there a reason that they should be infected? A lot of our patients will actually come in altered mental status. So your first thing you're going to do your Cincinnati stroke scale. You're going to make sure you're not having a stroke. Well, now we have not symmetrical weakness. We have weakness all over. So that should flag us, number one, that's probably not a stroke because you would actually have to have two different sides of the brain being affected. So now we have weakness all over. We have a patient with low blood pressure. He feels hot. His heart rate's up, and he's lethargic. We want to think sepsis. And all you have to do is just let us know that. This is a sepsis alert for us. Whatever way you want to tell us. You tell the nurse, you tell Dr. Sabati, whoever, you can tell us over the radio. The reason that you're going to help us so much is that I know if you identify it in the field, my nurse is already going to know in the back of their mind, this is possible sepsis. And then it's in their court to be aggressive and do the therapy that we know is going to work and give them the best outcome. So we will have some of these on your, I will have some cards to give you to put on the ambulances too. So early goal-directed therapy was introduced by Emmanuel P. Rivers in New England Journal of Medicine in 2001 to respond to sepsis shock. And it's a technique used, again, to make sure that we're having good outcome. The best treatment for sepsis is to get fluid on that person, IV fluid, 30 milliliters per kilo. I think that's on the next slide. And then to get their blood cultures and get their antibiotics going. Again, we don't care what the source is. We want to get antibiotics going, give your T cells something to fight with, and then we'll worry about what's causing the infection for you. So here's some of the medication treatments that we would actually do to treat them. The normal saline boluses to increase the tissue perfusion. We want to give antibiotics, again, broad spectrum until we can identify it. Vasopressors, if we give all that fluid and the blood pressure remains low, it's probably because the body can't respond anymore. It's exhausted. The sympathetic nervous system is done. So we have to give you actual pressors that's going to get your vessels more constricted, help you keep that blood pressure support that you're going to need. And then other medicines, a lot of times with sepsis, we get really funny blood sugars. They're very, very low, very, very high. It's like the body doesn't know how to respond to that. So we may have to give them insulin therapy and then some drugs to help with their immune response. So hopefully with early diagnosis and prompt treatment, good communication with EMS and us in the ER at South Bay, we can help really reduce mortality and morbidity from sepsis.